Apologize to people for that background sound. We've not had this happen before, and I'm not really sure what the problem is. So this is Mercy Byrne-Klug. We're going to go ahead and start the webinar, and I apologize in advance if there are problems with the sound. Welcome. We've got a really important and interesting webinar today. I should also mention that our handouts for today are on the National Nursing Home Social Work Network website. You can get to that through the University of Iowa School of Social Work. We want to thank the Retirement Research Foundation for their generous contribution to help support this. Bob, you're unmuted now.
Okay.
All righty. There's something about our webinar series. We've been having at least 2 webinars a month geared toward nursing home social service staff members, but actually open to anybody who works in a nursing home or who's interested in nursing home issues is welcome to listen to our live webinars. And then also we record the webinars, and this one's being recorded right now, and it'll be posted within 24 hours on that nursing home network website that you can get through the University of Iowa. If you have any questions during the webinar, please write to me through the chat box or put in a question and answer box. Put a question and answer in if you'd like to. And the recording's available within about a day. Let's tell you a little bit about today's format. We're in the welcome section right now. I'm going to soon introduce Bob Conley, who will actually be introducing our topic and today's speakers. And our first speaker will talk for about 35 minutes, maybe 40. And then our second speaker will deliver a case presentation. And then we're going to leave the last 15 minutes for questions and comments from the audience. So if you have a question or a comment, right to the end, please type it in at, when our question and answer session starts, which will be about an hour from now. The whole webinar lasts an hour and 15 minutes, and the last 15 minutes are dedicated to questions and comments from the audience. So right now, I'd like to turn the microphone over to Bob Conley, social worker. He has 20 years of experience at the Centers for Medicare and Medicaid Services, and in fact, it is Bob who served as the project officer for the MDS 3.0. Been very involved in that development. He's a planning committee member for this current webinar series committee, and he is actually the co-director of the webinar project. So, Bob, I'm going to turn it over to you.
Well, it's my pleasure to introduce a very important topic, promoting continence for nursing home residents. And as I said, I was on the project officer for the MDS 3.0 team. And continence is a very important issue for many reasons. Care, skin care, psychological well-being, the symptoms of urinary tract infection, often looking like psychiatric problems, etc. So I'm excited that Janet Specht and Sarah Varney are going to be our speakers today. Janet is the director of the University of Iowa Hartford Geriatric Center, has her PhD in nursing from BSN from University of Iowa and a diploma in nursing. And while I knew there was more to this story, and her research interests include practice models to promote professional nursing diagnosis, intervention, outcomes for older persons with urinary incontinence, and care for persons with dementia and their families. She's implemented a grant on evidence-based practice for pain management and continence promotion, and her partner and another great nursing leader, Mervyn Moss, have developed and operated an alternative living facility for persons with dementia for 5 years, and she owns a care management business. So she's definitely involved and really wants to promote knowledge, which I think is excellent. And then the co-presenter is Sarah Varney. She works in SNF long-term care dementia, 44-bed long-term care facility since June 2011. She has CSW from Winona State University, serves on the board of directors for long-term care social workers of Iowa, and formally recognized for her on wishes for her role with the iPost and the Pulse Forum. So I'll hand over to Janet.
I'm really pleased to be a part of this panel and an opportunity to talk about one of my favorite topics, which is urinary incontinence. And I titled the presentation today, Promoting Continence in Nursing Home Residents, because when we're going to talk about incontinence, our objective is really to promote continence and to help people maintain continence. So as objectives, we'll talk about what are some possible causes or contributors to people in nursing homes having urinary incontinence, and to talk a little bit more about what doesn't work with nursing residents related to incontinence, and then talk about successes or interventions for gaining or maintaining continence, and then close with a really interesting case study related to urinary incontinence. So with that, we'll begin. I think if you don't take away anything else from this webinar today, the next two slides are my most important messages. And first is that aging does not cause incontinence. So nothing automatic about getting old that makes you be incontinent. There are some things that increase the risk of having problems with urinary control, but they're not a direct cause. People get very old, still have urinary control. And many people who have some problems with control regain control. So I think that's a very key message to this. And secondly, if we look at the next slide, dementia does not cause incontinence. There's the assumption that if people have dementia, they could lose urinary control. And they because they're older persons, often with dementia, they've got some of the same problems that older people have, regardless of their ability. And then they have some additional risk factors, but it's often not related to their function as much as some of the other things occur with dementia, and we'll talk about that a little bit as well. Before I talk about what happens with aging with this slide, I just want to say that one of the reasons this is such a critical topic is that even though we know more about how to help people with urinary incontinence, the evidence is that less is done in homes about urinary incontinence, and that our main thing that we're doing now is containing urine, catching it, and there's much more that we can do. And so I think it's so important. Here's some of the things that happen with aging that increase people's risk of having some impaired control of their urine. One is there's a decrease in bladder contractility. The bladder is primarily muscle, and as we age, muscles often get less effective and get weaker, and because the contracting needs to expand as the urine as it's filling, and it needs to contract to get efficient emptying. When that doesn't happen, if it doesn't expand, then you have a decrease in bladder capacity, which is the next thing on the slide. And if it doesn't, because then you have ineffective gain, and you make people more prone to urinary tract infections, or that they don't empty their bladder completely, so they always feel like they have to go to the bathroom. So there are some things that happen aging that just increase people's risk. And it's all related to muscle, that once the bladder is full, then we have our bladder sphincters, which again are muscular, that close off the urethra or the tube that leads to the bladder out, and it can't that tube tight, then get leakage, which is on what we see, or the bladder is just empty. So it's harder and harder than delayed voiding. But these don't cause incontinence, but they predispose elders to it. And dementia, like I said, they have the same problems we just talked about that may come with age, but coupled with that may be impaired mobility, difficulty getting around, and the impaired cognition affect find the bathroom, just problems with wayfinding. There are some things that you can do in the environment that helps that we'll talk about. They also, because one of the losses with dementia is executive function, which helps you plan what you do. When you lose that ability, then you can't plan, well, when I usually have to go to the bathroom before I go to meals. Lose that ability, then you don't go to the bathroom at those times. And they might also lose the ability to recognize the urge. When you and I have full bladders, we can tell that and say, oh, I have to get to a bathroom, or you tighten your muscles so that if you can't get there. But that often is lost with dementia. Please. So some things that also contribute to loss of bladder control or urinary incontinence. Many of these can be corrected or modified, and this is what we would aim our interventions to, or our treatments to. One of the top ones is dehydration, and it's so intuitive, I think. I think that a way to have better urine control is to drink more, and convince people of this. But when people don't drink enough, the urine becomes concentrated. It often gets kind of smelly, but it also then, when it's concentrated like that, it increases urgency. And actually, people have to urinate more freely. It's more difficult to have control. So a really simple intervention is to promote more drinking. And social workers can do that with every contact they have with a resident, urge them to take a drink of water or drink fluids. So that's, sometimes older people don't want to drink very much at a time, so they need frequent kind of reminders to drink. Caution is another big factor. When the bowel is full, it presses on the bladder, increases the urgency. So having good bowel hygiene and having regular bowel movements. And there are some things, again, that we're about with healthy bladder habits. That one of the main things that some of the studies have found, where nurses evaluated people who were incontinent, was that they had a problem with constipation, and really that their bowel was full of stool. So again, that can be modified. Impediment is just the constipation that's not been treated adequately, and being much less of that now than in the past. Of constipation. Obesity is another contributing factor. Sometimes people just knowing that that's a problem, sometimes they could lose some weight. It's important to recognize this, especially since it's so much on the rise in our population in this country. smoking and caffeine intake both have effect on the bladder, increasing urgency. And the intake, are you saying something? Okay. Mostly the environment. So things like, into the toilet in time. People can say that the incontinence is a result of the loss of the space between the bladder and the legs. If you can't get to the bathroom time, the bladder empties. So having a convenient bathroom with a clear walkway to it, leaving the light on. For people with dementia, some studies have shown that if you just leave the bathroom door open, light on in the bathroom, it gets used much more frequently and reduces incontinence. Thing with the environment would be one of the things that I have noticed in many nursing homes is that there's a bathroom close to the common areas. Bathroom that's close to the common areas is often designated as the public bathroom, and residents are discouraged from using it. So looking at how is that in your facilities, and are we making sure that we make toileting facilities as available as possible? And then find these bathrooms. And if people are no longer able to read because of dementia, some visual cues like a picture of a toilet on it, or these Ann Getty's photographs that have babies in a bathroom that are attractive. Picture could also go on it, but those important things. And the other thing is the bathrooms that you go into in nursing homes or assisted living facilities. The bathrooms are all one color. The floor and the stool is white, and the wall and the stool is off-white. And so people with dementia have difficulty leaving the stool. And that's some of the reason you often see people go to the bathroom with dementia, go to the bathroom in a pot or in a corner. In the wall, the stool, a dark color, helps have some visualize the stool. Some have put blue water in the stool so they can see where that is, or a colored toilet seat that helps that. So many things that we can do with the environment that can be. Let's go to slide. Disease or impairments, and I guess I've talked about some of these. With this, the need to have good control of that. Surgeries, the surgeries that I'm particularly have been found to contribute to UI and prostate surgery, often leaves men with problems with or what we would call incontinence. That can be there can be help for that. It can improve. There's growth for improvement. Women who've had a hysterectomy are also more at risk. And again, there's help for that in terms of interventions that can be done. Function problems, in addition to mobility, which would be one functional area, but transfer. People who have, need assistance to transfer on and off the stool are at risk because it's sometimes hard to get the help when needed. Also, kind of managing clothing and hygiene. And one of the things we do is put incontinence or pads on people, and then that makes it even more difficult to get those briefs taken away so that you can manage toileting. And in clothing, you can modify clothes with Velcro of a zipper or button. You can wear split panties, so it's easier to do that to toilet. It's pretty common often to use sweatpants because it's easy to get up and down. So many things that we can help people manage their cleaning, because if you can't get your bathroom in time, but you still can't get your clothes arranged, still end up being incontinent. Is another area I want to just briefly touch on, and that if it's for people to walk or to move, then they're less likely to, or if it slows them down because it's painful. So very important to, when you're thinking about people who are incontinent, are they in pain, and are we there adequate treatment for that pain? And I really talked about, I didn't talk about all the things I want to talk about with infection, and one would be the urinary tract infection, and if it's discovered, it needs to be treated. And you don't have all the symptoms with urinary tract infection in older people that you see in younger people, but it's prevalent, and if you have a urinary tract infection, you'll know how much it increases urgency, and that's some of what leads then to the loss of control or incontinence. And the other source of infection is for older women who are postmenopausal or no longer menstruating, and for loss of estrogen, being at risk for vaginitis, sometimes called senile vaginitis or atrophic vaginitis. And this in a virus, beige color drainage, but also then it inflames the urethra and the vagina and area surrounding that, and then it makes that interferes with makes urinary frequency more common, and it's very treatable with just a total application of again, I think if we need to do some adequate assessment and see which of these things might be leading to the incontinence, and to treat those or modify those. I think this is a real critical part of thinking about urinary incontinence, really the underlying philosophy of treatment. And many others as well, see acceptance of incontinence as an inevitable consequence of aging or dementia is really a manifestation of discrimination and ageism, and inconsistent with person-centered care. And I think one of the evidence of that I see or have seen is that people go to the bathroom, people who are living in a nursing home. And my friend was living in a nursing home, had a incontinence aid on, and said, you know, I need to go to the bathroom. She was said, well, just, you've got incontinence aid on, just go. That is what it's there for, to catch. So, not the dignity of assisting her to the bathroom and letting her helping her to maintain control, but rather kind of promoting just up what that does to the person's their feeling of control, and of self-worth. And if, as often they have heard is people are helping make people try the resident will often say, "Oh, I'm such a baby, I just can't dig anymore." And so about the and psychological consequences of incontinence and how that impacts the person is really critical. So I see much of the problem in the treatment of urinary incontinence is problems with attitudes and knowledge and actions of healthcare providers. But other people themselves and the family and other caregivers believe this information or don't have the current information to know that we can do more about it. Next. Treatment really is to restore and improve continence and to improve the quality of life. And I can't emphasize enough how much quality of life is affected by the loss of continence. And there's been worse. But she sees that as one of the major urinary incontinence as one of the major social problems in nursing homes, and I certainly agree with that. And there's been a number of studies that have shown when people have urinary incontinence, they report much less or poorer quality of life. Next. So I spend a lot of time on consequences, but there are physical consequences. There's most everyone who has regular incontinence also has some skin infections. It's one of the major risk factors for pressure ulcers and for urinary tract infections that may then lead to sepsis or very serious infections. It's a major risk factors for falls, which then lead to fractures. So it underlies a number of other problems that we spend a lot of time with in homes that could prevent it if we would work on this kind of underlying problem of incontinence. And I just talked about, we see a lot of cycle problems, the altered self-image, the depression, and people who have problems with urine control are just not very sexy, and they identify that as ability to have individual relationships. And so people often will isolate themselves. Families often also are more reluctant to take people who have problems with urine control in their cars or out for the day. Like that even if the person wears a pad, they don't know how to deal with that. And of course, it's one of the leading reasons that people get to nursing homes and to many. Again, the decreased quality of life. Next. So, things I can't stress enough is that there really has to be good assessment. This needs to take place whenever someone begins losing urine control. So if you're at an MDS meeting and the person has switched from being continent to incontinent, that ought to trigger a very thorough assessment. Or if a person comes in, is admitted with problems of incontinence, it ought to trigger a thorough assessment of the problem of the urinary incontinence, and not automatically just start people wearing pads. Include the things like what their past history, how long have they had problems with this. The PAR means a post-void residual, which is emptying their bladder completely. And some reasons it's so important to know these things is that to treatment. Someone has overflow incontinence, which comes because the bladder doesn't empty completely. It doesn't matter it will be helpful, or it won't, if they're incontinence, to toilet them regularly. There has to be something done with the ability to empty. So to make the best use of our resources and the rest time, and to have a good treatment, a successful treatment, you need to know the type. You need to know the pattern. Most of us have a pattern to when we empty our bladder. When we get up in the morning, maybe before we go to meals, maybe morning, mid-afternoon, before we go to bed. It's predictable, and everybody has that. And we know that particular pattern for the residents that we're working with. And, ways we do that is a bladder diary. The bladder diary is a thing that needs to be done. I think, well, some places have implemented it on admission of everybody who comes in with a problem of urinary incontinence, or it be done once you have a change from incontinence to incontinence. And one of the reasons to do that is first to find their pattern, and you usually look at both bladder and at fluid intake so that you can see, okay, so the person took in a lot of fluids at mealtime, and their usual pattern is they can go about a half hour after a mealtime before they have to empty their bladder, so that you begin to see their usual pattern of when bladder empties. You could develop a program of helping them toilet then. It also helps you see, oh, this person has 2 episodes a day of urinary incontinence. Maybe we can help reduce that or take it away. Or they have 6, and you could get that to 2. But you don't have baseline to look at, to evaluate. Then you can't staff, you get this person to the toilet is really working, because look at how we do these episodes. Or talk to the resident about, you're really making a great effort to toilet, and that's really helping you, what you could share with the family. So I see that bladder diary as very critical. And our next slide shows a picture of that. No, more about, here's the picture. So drinks, when they went to the bathroom, when they had accidents, they feel a strong urge or not. This helps you know if it's urge incontinence is one of the types. And sometimes what you were doing, because types of incontinence like stress incontinence, when is coughing or laughing or lifting something, is when they have these problems more. So it just helps you identify the type. Use this one of the handouts so that you can see this. It's pretty easy to fill out, but they're very hard to get done consistently. Another thing that people have to do, residents that are more capable can do some of this. When we've done some with residents in assisted living, they just got so anxious about it, about doing it right, and we're about forgetting that if that happened, we just had staff ask them about it and fill this out. Slide. Talk a little bit about what doesn't work. And so I probably said as we've gone along, but I say the biggest thing that doesn't work is assuming that nothing can be done. We can try things for everybody. The factors about this is try it, and you probably need to try it for more than a week. I think 2 to 3 weeks if you have a plan. Try it, and then if it doesn't work, look at the next step. I think one of the things nursing assistants have reported repeatedly is that they never get stopped. And so it's not working. We shouldn't keep doing it. So that's as important as doing something, I think. And when we did some chart reviews in special units for persons with dementia, we often people got started on medications, for instance, for emergency, and with no evaluation of did that reduce the incontinence. These meds just went on for a long, long time. So I think that's the problem. If we don't continue to look at, is this helping? If it's not helping, let's either do something else, but for sure, let's quit doing what's helping. We've got minimal resources to use, and we need to make the best use of them. The second thing that doesn't work is doing the same thing for all residents. So toileting everybody every 2 hours is that doesn't necessarily keep everybody continent. Some people can go 4 hours, and we would save some staff time and be able to get some other people to go at different times. So it's really trying to address the individuality of them, which makes a more successful program. We did a study in 48 nursing homes in Iowa, and people wouldn't complain that we had this great plan for the resident, but never complied with the plan. And when we talked about it a little further, we said, well, we ever talked with the resident about what the plan is and whether they were willing to do this and would it work for them or not. And found no, that hadn't been done. Urged that resident be included, and family too. The family can be quite supportive if they understand what's being done and can be a good reminder to the resident. And again, I think that's a great role for social work to be involved in. And then what I taught regarding assessment, that if you don't get evaluation of what's happening before you start trying to do something, they don't get very good results, or even things that don't work and could need that up front. And then failing to consider the psychosocial consequences of urinary incontinence. And again, this is a huge role for social workers to help all staff understand how having lung control is affecting the person, how they view that, and why it's important to do something about it. To the good part about what works, please. Intervention. Starting as that, you know, the person has problems with incontinence, getting something started. That ought to come out of the care planning conference and begin to work on that. There should be only quarterly, so if something comes up in between, I think we can jump on it. And we know that the sooner that there's intervention with loss of control, the better prognosis that control is returned. So lots of evidence that we need to get off early. Letting residents, staff, and family know about urinary incontinence and about how there's successful treatment, and help understand what those are. There's a really good that is for education, and I don't think I've included that on the resources, so we'll need to get that put up as well, and we will. That could be used with residents, staff, and families. About in terms of trying to measure the effectiveness. Lots of times, if people don't know what's working, they're not only to keep it up. And this isn't a quick fix. Often it takes a number of weeks to get improvement. And people need encouragement. Well, you're doing better, and looking at this. And it can be things about incontinent episodes, but it could be involvement in activities outside their room. It could be looking at odor control. There could be all kinds of things that you judge the effectiveness depending on what the people identify is a problem with their incontinence. Does it keep them from going out? Does it keep them from leaving their room? And increased sensitivity to the impact of urinary incontinence on persons. In this study we did in assisted living, staff said, well, you know, people just don't want to talk about urinary incontinence. That wasn't true. When the person that took the time and was interested, there was privacy. People to talk about it and wanted to talk about feel and what they would like to do with it. Very anxious to have something done and very pleased that there's an interest in it. One of the things we did find is that men and women wanted to be approached separately. They very much didn't want, they didn't educational preaching where both men and women were there. We did the men separately. They had a lot of questions. We did the women separately. They had a lot of questions. We tried to do them together. Nobody came. So being sensitive to how people view the problem of urinary incontinence and how painful they feel it is often. We tried to make a video about urinary incontinence, and one of the persons that was living in this assisted living was a faculty person, a nurse, had retired from the College of Nursing, and she did not want to be video about urinary incontinence because she did not want anyone to assume that's a problem she had. So I think, you know, it's a pretty pervasive feeling that this is kind of shameful thing and I want to be identified with it. Looking at environmental barriers works. You can, like I said, leaving doors open, lights on in the bathroom, accessible toilets. Advocating for these kinds of things are really important for staff to do. And encouragement to staff and residents that, you know, it's a good thing that you're working on these problems, and we know it can be overcome and things can be better, and it's important work. Slide. I got a minute. So these are effective interventions. Habit training, which is looking at the person's pattern, avoiding or accidents, and setting up a scheduled time to help them get to the toilet. And then from that would be a new habit developed. Avoiding is just an addition to habit training, where you might go in and remind the person that they need to go to the bathroom or assist them at the time it's supposed to be, and you would praise them if they're when you go in and if you use the toilet, if they use the toilet. So it's positive reinforcement. You don't judge if they're wet. That's also been quite effective. And 50% improvement for both habit training and prompted voiding, even when the person has cognitive impairments. The changes are a very effective thing, getting bathrooms close and accessible, visible, and promotion of healthy bladder habits. And I think this is something that needs to be done for all residents. That's why having some educational things would help. If we look at this last slide, let's go on. Overview of the healthy bladder habits. So you can see a little bit more about and you can read those things. But in terms of healthy bladder habits, also need to have adequate fluid intake. As long as you don't have, so it'd be 15 to 2,000 a day, about 2 quarts of fluid a day. If the person has congestive heart failure, it would be less. But in my master's study, I had trouble getting people to 500 or up a day. So it'll take a lot to get to 1,500. So if you can just get people to increase their fluid intake. So serving a glass of water at meal times is a way to do that. Remember to drink each time you have an interaction. Bowel function, weight, all the things I've talked about. Smoking, physically fit, being around. So walking interventions are the ways also to have healthy bladder habits. About each of those, and I think we need to turn it over to Sarah to do the case study.
Thanks, Janet. My name is Sarah Varney, and I'm going to talk about a case we had in our facility regarding managing incontinence. Mr. who is a resident at a long-term care facility, has a diagnosis of dementia and is incontinent of both bowel and bladder. However, at times, he does realize that he needs to urinate, but doesn't know to use the toilet or even what the purpose of a toilet is anymore. Because of this, Mr. X has a habit of urinating in inappropriate areas, such as potted plants, trash cans, and common areas, which upsets and bothers the other residents. This happens on average about 5 to 7 times a week. Please. From Mr.'s perspective, he does not perceive that there is a problem. He uses his best judgment to determine where the appropriate area to urinate is and does so. Mr. X's family lives far away, but is aware of the progression of his dementia. They state that Mr. X would be appalled by his own behaviors. The nurse staff at the long-term care facility considers Mr. X's behavior to be unmanageable because they are unable to predict when he will urinate in an inappropriate area. Next. Outcomes for Mr. X were that he no longer urinates in inappropriate locations, such as the common areas of the long-term care facility, and reduced his episodes of incontinence. Next slide, please. A care conference was held with the nurse, social worker, and Mr. X's family, and it was suggested that staff take Mr. X to the bathroom every hour as needed. Also, an intervention that Mr. X wear overalls was put into place, which would help prevent him from pulling down his pants in public areas. This intervention, however, bordered a fine line of whether or not it would be considered a form of a restraint, since it prevented Mr. X from being able to pull down his pants. This was discussed with Mr. X's family, power of attorney, and they were in agreement of the intervention. Next slide, please. Mr. X's care plan was updated to include that he would be put on an hourly toileting schedule and that staff would dress him in overalls. Immediately, staff noticed that Mr. X's episodes of incontinence decreased and his continence increased, since able to void more frequently. Staff also realized that Mr. X would become more restless and anxious when he needed to go to the bathroom, since he was unable to pull down his pants independently. They were able to help him to the restroom immediately. X's incidences of urinating in inappropriate areas decreased significantly and became isolated incidents, only happening about once a month. Next slide, please. As a facility, we let more frequent intervals and toileting schedules helped minimize episodes of incontinence in our residents and actually promoted increased continence. For those in our facility who also have frequent episodes of incontinence, we begin toileting them more often, and we have received similar positive results as this case study. So I will do Janet so that she can go over some of the resources for this.
Well, all right. This is Merce. I was going to just talk a little minute about this article about urinary incontinence and promoting continence. Janet, I'm going to take from you and talk more about promoting continence rather than dealing with incontinence. This was an article that Janet and I worked on with others here at the University of Iowa in terms of expanding the role of long-term care social workers related specifically to urinary incontinence. And one of the tables in that article is now for you, and I'll post it on our website as well. What we did is we took the NASW objectives for long-term care social workers, and we applied those objectives to addressing urinary incontinence or trying to promote urinary continence. And so we went through to see what would the NASW objectives look like if applied to urinary incontinence. And so, for example, the first one up there, a pre-admitted admission screening, ask about this, and all that. So that's available if folks would like it. And then also we have, do you want to say a word or two about these resources?
I'll try to do it quickly. There are a number of resources that you can find out more information about the treatment of urinary incontinence or the way to promote continence. And Continence Nurses Society is one such group, and it is really a source of networking and more research related. It's something that you might recommend to the nurses in your facility to look at. There's also some funding for some projects available through them. Let's go to the next one. National Association for Continence, or NAS, I guess it would be called, is really an excellent resource, and it's dedicated to improving the lives of individuals with incontinence. So it has, as I downloaded the Bladder Diary from, so it has a lot of material that can be used. It has material that you could share with lay people, so with families and residents about this, or that you could go to get more information from yourself. So looking at that website would be a good thing. Place. There are a couple more. The Harvard Institute for Geriatric Nursing has a website called Consult Geri RN, and they have some specific things for urinary incontinence on this. They're one-page guidance series that are very helpful for nursing staff, and I think would be also useful to social workers. And the last one is the Society of Urological Nursing Association, and it's more clinically oriented and less to like. And the resource, I would be very happy for anybody to email me with questions or things that they have that maybe don't get to today, and put that email up. We'll leave the questions.
Thank you. And I'm putting on the chat box Janet's email for everyone. Yes, let's have some questions from the audience. Go ahead and put in. If you have a question, tell us a comment. Is this the first time you've got information about promoting continence? Give us some reactions or some responses. I did have one of our attendees say in this comment, free homes recommend they start with 1 or 2 incontinent residents and ask the staff to select the low-hanging fruit, that is, the person they believe could be continent. Then use the Bladder Diary for 2 weeks and develop a plan for that person, showing that I suppose that if you can build the confidence of the staff in these procedures working, that's one to make change too. So perhaps start small. And I want to thank Charlene T. for sending in that comment.
Exactly right. I think if you think about everybody who is incontinent, how you're going to approach that in a nursing home, it's overwhelming. And so that she suggests is exactly what we did in our study, because we thought that was a great way to do it.
You mentioned that dehydration was a contributor to incontinence. Could you explain that again, because it just sounds so counterintuitive?
We don't take enough fluid in, then the urine becomes very concentrated. It's concentrated, it's an irritant to the bladder, and it triggers the bladder to empty. You have more frequency and more difficulty with control. And if you drink more fluids, then it dilutes the urine, and it also gets the bladder fuller, which is helpful in triggering the emptying.
Okay, wonderful. Thank you. Other point is the way the staff can model to all the residents and to the family how people who are experiencing incontinence are treated. So I think not, talking with dignity to the person who's experiencing the incontinence, but also to the residents who may have noticed or who are around the area, that they know that in your facility, people experiencing incontinence will be treated with dignity. Because, before the grace of God any of your residents could be experiencing at some point some incontinence, and you want them to know that their dignity is going to be respected. And the best way to do that is to respect everybody's dignity who's challenged by this issue. And so to kind of make sure that the culture in your facility is that we respect residents, and we're not going to be, making fun of or dissing people who are challenged by episodes of incontinence. The issue, Janet, that you mentioned that I'd like to ask you to elaborate a little bit on is the whole issue of family taking residents out for a visit or out for going to the restaurant or something if the resident is at high risk of being incontinent. Well,
there's something called social continence, and generally, against this wholesale use of incontinence products, pads, or I insert something here that often these are called diapers, and I think one of the first things we can change that contribute to loss of dignity for residents is use the term diapers, because it implies babies wear diapers. It implies that they're baby-like, less able, and think it's real important to call them briefs or incontinence aids or pads. I have to say that, I guess.
Thank you. That's helpful.
And the second thing is that rather than use those all the time for people, it maybe help them use it when it's most important to them. So that they don't have to risk the possibility of losing control. So they're going to go out with family. That'd be a time to have them wear an aid if they want to, or if they're concerned about it. We've worked with families before to learn how to do that if they need to. But many of them pads now, they're developing all these pads that you could go 12 hours without having to chit because so absorbent. a possibility, and then they say that there's no more skin problems, those than others. The possibility that they could go with family and not change the pad is possible as well. So I think it's being taking lead from the residents often in terms of what's important to them, and then following along with that, but encouraging them to try out the pads when they're in safe places so that they could try to regain continence.
Sarah, a question for you.
Sure.
About how long did it take to see any improvement with that resident in the case study?
We actually saw improvement immediately for him, both because we had the intervention of him wearing overalls and also toileting him every hour. He had a lot more opportunities to avoid inappropriate places, and then also he was unable to physically pull down his pants. So when staff saw he was like getting up and just kind of become a little more restless, they knew that he had to go to the bathroom, so they were able to take him more often. So we saw that he improved immediately.
Okay. And so is it a nursing facility in the state of Iowa? So residents wearing overalls, that's not that unusual in Iowa, but that may be a little bit unusual in other parts of the country. So you'll just have to think about that.
They make jumpsuits that look kind of like sweatsuits, so you can't really tell that it's a one-piece suit, but they do make those.
Okay.
So that's another suggestion as well.
Thank you. Bob, did you have a comment or a question?
Yeah, Jeff, this was very helpful. I guess I have two thoughts. When I worked at CMS, our Jack Snelly did a number of presentations in which he showed how incontinence management and getting people up and actually had people exercising while they were going to the bathroom, prevent falls and improve care. But he never sell that because the facilities felt that wasn't what they were getting from, and it was very much a culture change. So one question is, some of this is kind of a culture change, that if you have a staff to aid ratio in an assisted living or you've got turnover, it's kind of hard to the staff to kind of believe this, and yet in the case that Sarah talked about, that it really was one that it worked. And the second question that, this is an issue that often I work more in hospitals and nursing homes, that a social worker advising the nurse about to do continence on their patients might be seen as politically incorrect, and how a social worker might approach the nursing that may need some education in this area.
Okay, first about work. I think it's kind of where we are with just like there's lots of evidence about what can be done for treatment, but we move that from to practice. That's kind of been a conundrum to keep working on, and I think one of those ways is to look at and the first person that had questions or had a comment, I think her approach where you take a couple of people, have a success, and have everybody in the nursing home pay attention to that. So, like, maybe there would even be something in the letter from the nursing home saying, we're making an effort to help people to promote continence, any of our residents as possible. And these are some of the things we're doing, and I want to recognize Merce, who has been really championing residents who want to regain continence, or want to recognize the dietary department who are serving more fresh fruit so everybody can have who less complications that might lead to incontinence. But to begin to have the whole facility pay attention to this, I think we should to whether people get their work done time, whether the meds all get out, documented, and continence doesn't have the same kind of validity in addition to it. And I think it can be done in tasteful ways.
Janet, to do of resources, does it save resources or cost resources to keep people continent? It seems like if people are not continent, there's a lot of effort too.
NLA has done some research that shows that it takes more resources, but I think it depends on what resources you look at. If you think about how often people with dementia get combative or resistive when you have to change wet clothing.
Yeah.
If you get the cost of people feeling bad about themselves and being stressed and how you treat the depression, I think there are a lot of costs in that way too. So I think there are positive consequences of improving continence. Just have to keep looking at those. It's not always a time saver.
And about Bob's point about ideas about how social workers could, with nurses, to not, not talk as though they're getting in the nurse's turf or territory, but what would be good ways to start that conversation in a way that would be not offensive to a nurse, a director of nursing?
Definitely address that. For me, I see the biggest part of the job is to be an advocate for our residents. And so when it comes to incontinence, if there's any way we can help them lower their incidences of having incontinent episodes, definitely I want to be their advocate. And so when I sit down and talk with the nursing staff about it, I try to get ideas from them on how they feel they're able to handle it better. And so I think by having them be a part of that problem solving, I think that helps a lot in that it's more of an equal effort of trying to deal with the problem than I'm telling them to do something.
Okay. That you're not saying that I'm the problem and you do something about it, but this is the problem and what can we do about it together?
Exactly.
Yeah.
I'm going to invite people in the audience to just type in the chat box and tell us what one change you can make in your nursing home today related to promoting continence among residents. So go ahead and type it in the chat box and I'll read it out for others. Any other questions or comments from our speakers or Bob?
This is Bob. The other question I had, Jen or Sarah, when urinary tract infections occur, that often people have medical symptoms that are missed, and bacterium it could be part of that. Is there what are signs to look for, or how to help look at it? It's not just a psychiatric problem, but maybe that out first.
Yeah, I think one of the first that needs to be done if you have a change in people's cognition, even a change in their cognition, even if they have dementia, or change their behavior, is first look, are there physical symptoms at all? And then investigate that. And I often, with urinary tract infections, you see the delirium. You see, and I always think of delirium, I think, as more agitation, but the more common ways that delirium is less activity, kind of silent or very inactive. And so that feedback food into that's also when you see this kind of people wanting to get up, sleeping more than they've ever slept before, that you need to do investigation and assessment too. I have something to add to that.
Bob, repeat your question for me, please.
That sometimes when a resident has a urinary tract infection, that can create symptoms, agitation, or behavior, and as Janet just said, could be that are treated as psychiatric or behavioral management, where really the underlying cause is urinary tract infection or some pharmacological combination. And I just wondered if you see that.
Usually, if we notice that a resident is not acting like themselves, such as increased behavior, smoking habits, mood, we generally go ahead and do a urinary analysis for them right away. It's one of our first steps to out, and then if it comes back that's negative for a UTI, then we explore further. But doing a urinary analysis is one of our first, mentions if someone has those increased behaviors.
And both alluded to something very important, and that is the regular staffing. That in order to notice these changes in a resident's status, you need to be very familiar with the resident. So you need to know what is a change. And so keep turnover in nursing homes low if possible, or to the extent possible, and also routine assignments so that the same staff are working with the same residents can help bring these small changes to the attention of the staff a lot quicker and a lot sooner. So anything to do to support that steady staffing is important too. Well, the last comment is going to go to Amanda A., who wrote in that she is going to pass along this great information to the rest of the team at her facility because it's truly a team effort. So I want to thank everybody for being part of our webinar today, and we will have a recording of this posted within the next 24 hours. And then those of you who are part of this live, when you sign off, you'll be sent to an evaluation screen. Please indicate if you would like us to mail you a certificate of attendance. It'll be email. We don't have any postage budget, but we can email you a certificate of attendance for attending this live webinar. Thank you very much, everybody. Happy New Year, and we'll see you next week. We've got another webinar coming up. So please check the website and share your feedback and ideas with us. Thank you so much, everyone.
Bye.